more people will join. Great. Well, welcome everybody to the Stanford Medicine Center for Improvement Lecture Series. I'm Laura Holdsworth, and it's my privilege to introduce our speakers today, of which there are three. I had the distinct pleasure of working with them as the external evaluator on the project they're going to present on today. Their achievements and accolades individually and cumulatively would take far too much of the hour to go over. And because I want to leave most of the time for the presentation and discussion, I'll give each of them just a brief introduction. So firstly, Dale Lupu is a professor and researcher at the George Washington School of Nursing. She is really a national leader in the hospice and palliative care movement. And just one example of this is her work on the Measuring What Matters national project, which recommended quality measures for hospice and palliative care programs. Next is Dr. Woody Moss, who's a nephrologist and palliative care doctor and professor of medicine at the West Virginia University School of Medicine. He's the chair of the Coalition of Supportive Care of Kidney Patients, and is really an amazing educator who I got to witness working firsthand. And lastly, Glenda Harbert is an experienced nurse in nephrology who served as the executive director of the ESRD network of Texas. She's a quality improvement expert with over 40 years of healthcare and quality management experience and has led numerous collaborative projects to improve outcomes for patients with end-stage kidney disease. And so as usual, if you have any questions, please go ahead and put them in the chat, which I'll monitor. As well as our presenters will be monitoring as well. And I'll go ahead and interrupt if there is any questions, clarifying points, but we may try to keep some of the questions for the end for the discussion. We'll aim for about 30 to 40 minutes of lecture time and save some time at the end for questions, and we'll try to wrap up a bit before the hour. And so with that, I will hand over to our speakers.
Sure. So Dale, let me just comment on the 12 crossed out and the 5. We decided to be kind to you and only go through 5 lessons in the limited amount of time, but we've given this presentation with regard to 12 lessons that we've learned. Oops. Okay, Dale.
Yeah, so welcome. So we're going to try, my understanding is that those in the audience, that you're a mix of clinicians and quality improvement folks and researchers, maybe from all different backgrounds, and hopefully we're going to give you a little bit for each of you. So first, I'll just tell you about the Pathways Project as a whole. It is based on the Institute for Healthcare Improvement collaborative breakthrough model. So it's a learning collaborative, distinct from and more involved than just an education intervention. It really is based on people coming together, choosing their own, within the topic that you're working on, choosing their own goals and developing projects to make improvement in their own settings, but then sharing that with each other and sharing, not just learning from the faculty that's overall, but really sharing with each other what they've tried and what works. They start with what's typically called a change package. And in the change package that we put together to start you can see a picture of the graphic here, and then it goes on for each of those best practices. It has a very short summary of the evidence behind it, and then kind of short suggestions about how to implement that best practice. And that's what we started with, this change package, these evidence-based best practices. In collaboration with the evaluators at the Stanford team, we had a lot of discussions about what the evaluation itself was aimed around. In other words, were we evaluating these, whether the best practices worked, or were we evaluating the collaborative? And our evaluation is a little bit of both and raised very interesting questions, which I would suggest some of you might want to talk about later, about in implementation science, how do we actually scope the what the implementation is, how we evaluate it. We chose to focus on 3 of these 14 best practices, and we'll talk about the next slide, Woody, because we realized that all of them would be too much. So I also will say we had 11 dialysis centers who were working with us, and then 3 CKD, chronic kidney disease clinics or nephrology practice offices that were associated that see patients upstream. And the overall goal, what we're trying to accomplish in Pathways is to bring more what we call kidney supportive care or primary palliative care, to bring more of the palliative care approach into the care of patients with kidney disease. We were focused primarily on patients who were already on dialysis, although, as I said, we were also looking at upstream before people come onto dialysis. Out of all the practices that we said in that change package makes up comprehensive kidney supportive care, we wanted to focus on three things. The first was identifying seriously ill patients. So who is it who really needs palliative care intervention and support? That's that practice. And then having goals of care conversations with those patients. So finding out what's important to them and what they're hoping for. And then once you find that out, offering some alternatives other than the standard dialysis or stop kind of approach. And we looked at a pathway towards the end of life for people who might want to withdraw from dialysis or might want to adjust the typical dialysis approach. So I think I'll turn it over, Woody.
Okay. So the first challenge was to identify our target audience for intervention. We wanted to identify seriously ill dialysis patients, and I have done some previous work and others have done some previous work showing that the surprise question, which I have at the top of the slide, would I be surprised if this patient died in the next 6 months, worked well to identify the sickest patients. So the first thing we learned is that it was really feasible to get these real-world dialysis centers to screen their patients with the surprise question. You can see 98.8% of the patients were screened pre-COVID. It dropped a little bit during COVID, but still was very reasonable. And they identified 18.4% as being seriously ill. And you can see that the screening was fairly consistent during the pre-COVID period. And even the percent that they thought were seriously ill was consistent too. Then what we then did is we followed those patients longitudinally to see, of those that we had screened as seriously ill, how many of them died during the 14 months of the Pathways project. And what we saw on this slide is that you can see over the 14-month period of time, 52% of the patients who were screened as seriously ill were the ones who were screened as seriously ill. 52% of the deaths were among them, but they constituted only 18.4% of the patients. And if you look over here in this box to the right, the cumulative risk was 50% of death for the seriously ill and 10.5% for the not seriously ill. So the risk ratio, if you were seriously ill, the risk of dying was 4.79. What's interesting is pre-COVID, we had also calculated numbers, and the risk of the seriously ill dying pre-COVID was only 27%, and the risk of the not seriously ill was only 3%, and the risk ratio was 8.5. So basically what was happening during COVID is dialysis patients who were not thought to be seriously ill were dying to a greater proportion than the seriously ill patients. So when we asked the dialysis centers, why do you think that happened? They said, well, actually, our not seriously ill patients were really up and about more and perhaps could have been exposed to a greater degree. That was their hypothesis, but it was sort of an interesting finding with regard to, yes, the surprise question was identifying patients at greatest risk, but during COVID, that, was not quite as good because, the COVID-19 pandemic was an unexpected finding.
And Woody, can I jump in?
Sure.
But just in a collaborative, in a learning collaborative like this, as you're collecting data, you're feeding it back to the participants. And the structure was, we planned to get everybody together in kind of mini 2-day conferences 3 times. So we had them for the first conference. We did a lot of communication training at that first conference. They came back about 6 months later for the second conference. And then the third conference, we had to switch to online because of COVID. But and then in between those in-person conferences, we were doing monthly webinar interactive sessions. We called them the Pathways Action Calls. And they brought cases. We looked at intervention and implementation together. But what was striking is when we gave them the initial data, sort of their first, I think it was 4 or 5 months of data, when we fed that back to them, all these light bulbs went off. They, in conjunction with a couple of other exercises we had them do around auditing their last 5 deaths in their dialysis center, they really recognized that they were missing an opportunity, that when they just kept putting off goals of care conversations, they were really missing an opportunity to intervene in a way that could help patients. And I think we saw a real reinvigoration, a real realization. This is something we need to do, and we saw that as a team when we saw this data.
So one of the challenges to implement this, I'll just elaborate a little bit on what Dale said, is nephrologist buy-in. And when the nephrologists saw how powerful the surprise question was in their own hands, that they were picking out these patients that they thought were seriously ill, and the risk ratio was 4 to 8 times higher than the ones that they didn't think were seriously ill. And then when they saw them going to the hospital and then coming back and then dying before they got a chance to talk to them, they never were learning really their preferences for end-of-life care. So I think you're right, Dale. I mean, we really had the nephrologists jump on board, within the first 6 months, because they saw we had given them a tool that was going to help them. Next slide. Glenda.
Hi, everyone. Thanks for joining. So during all of this breakthrough initiative, there was constant learning going on. And the staff discovered, among the many lessons they learned by the teams, is that a systematic approach with teamwork and flexibility really enabled them to conduct more goals of care conversations. Each site tested and utilized various approaches that included nephrologists delegating leadership for the conversations to advanced practice RNs, MSWs. And the reason for that was really just a lack of time on the nephrologist part. In all honesty, there are nephrologists who are more engaged in this work than others. And really, sometimes the APRNs, RNs, and MSWs were really the best people to be approaching patients. Also, among the various sites, team configurations varied with configurations, APRNs, RNs, MSWs, either acting singly or in teams to conduct the conversation. And one thing that was tested and proved really successful with some sites is scheduling time for the conversations. And this included scheduling with the physician's office time or with the individual staff members in their daily schedule, which made this possible for them to integrate it into the dialysis workflow, which we feel is important. We'll say more about that later. Also, with coaching and modeling, the teams learned that goals of care conversation is not a single event. It is a process that happens, and it does not necessarily need to involve a formal meeting in a conference room with the whole team and the patient and the family, which is very difficult to put together. So they learned that conducting goals of care conversations chairside was effective and was much easier for them to incorporate into their workflow. They discovered that these could very well be conducted by phone, especially during the pandemic, and it made it much easier to involve the families as well. We had several sites that had very diverse populations, and translation lines were successfully used to communicate with patients and families who didn't speak the language of the staff. Next slide, please.
So one of the evaluation tools we used was a homegrown survey that we called the Kidney Supportive Care Implementation Quotient. We did this as a pre and post survey of the staff. It's based on an AHRQ scale where we ask, how well does your practice do this? And people rank it 1, 2, 3, we don't do it at all. We do it well, but could improve, or 3, we do it really well. And the darker orange bars are the pre This is overall. And the yellow shows the increase. And after we're working with them for the full year and a half. This is in order of how much change there was in each of the practices. And what's significant to us, not statistically significant, but meaningful to us, is that the changes that ranked up at the top with the most change, staff assessing the most change, were routinely screening patients, what he just told you about. We gave him the surprise question as a tool. Developing a pathway for non-dialytic care, medical management without dialysis, which we worked with several groups of the CKD sites on. Having goals of care conversations with almost all patients, encouraging advanced care planning forms to be then put into the record, and quality improvement to support that was specifically around supportive care. And these are the things that we worked on. So we took it as very confirming that staff did indeed feel like they were getting better. What you can't see here is that there was quite a bit of variation between sites as to how well they did on any one of these things. And that again goes to the value of a learning collaborative, where if one site was really doing something well, they would share with other sites how they did it. And if another site was really struggling, they could ask for some input and suggestions. Next slide. I think this is my slide. Yeah. Yeah, go ahead. Next slide. Yeah. So here's what some of our big picture learnings were, both about the interventions themselves, the best practices themselves, and the collaborative. First of all, even though we had these 14 best practices and we would like to see that all of these get incorporated into care of people with kidney disease, it was just too much to do in a year and a half. So it was important that we identified these priorities. We got input from the sites. That's how we selected these as the high priority ones. And even so, we barely got to our third one of palliative dialysis and a kind of withdrawal pathway. We had big plans to work on symptom management, all kinds of other pieces, which we just couldn't get to.
Box 4 is not available. At the tone.
Well, somebody needs to go on mute. Also, initially, and this might have been my own naivete about how healthcare systems work, we initially envisioned looking at the whole continuum and really being able to have the CKD practices and the dialysis centers work together. After all, nephrologists in particular are working in both of those settings. But the siloed nature of dialysis centers is very strong. And we encountered that, and it made it very hard to do as much as we wanted with the upstream CKD piece, although we made some progress. And that progress was we developed a toolkit for providing what is often known as conservative care. We prefer to call it active medical management because patients tell us they like the sound of that sort of active medical management better. And we developed a whole toolkit, which we are hoping to test soon with another grant.
Yeah, Dale, if I could just comment about the siloed nature of dialysis centers, it was incredible to us. Glenda and I visited several dialysis centers, and they had advanced directives on their patients. And the hospital to which they usually sent those patients did not have copies of those advanced directives, so really had no clue. So actually, some of the quality improvement projects that Glenda really shepherded them through were things like getting the advanced directives to the hospital medical record system so that your patient's wishes would be known. It was incredible to us how there was not a continuity of care or the possibility of a continuity of care for these patients.
Next slide.
Glenda.
Yes, so of course, sustainability is a key challenge in any quality improvement activity. The outpatient dialysis centers lack a formal quality infrastructure and support that exists in institutional settings, such as hospitals, where breakthrough projects are normally conducted. And so this was a challenge utilizing the approach. However, by CMS regulation, a quality assessment performance improvement process is required. And this provided an avenue for us to build our quality improvement efforts. So we utilize this framework to encourage sustainability based on a foundation of a patient-centered culture. The pillars towards goal concordant care included at least 1 to 2 metrics in their quality assessment and performance improvement program. And this was very important for them, not only to measure their ongoing progress and identify opportunities for improvement, but then to work towards sustainability at project end. Also, systems and processes, independent of the people involved. You all know in your quality work that you have champions that come on board. They're enthusiastic, they lead the change, they can drive change. However, what we found is that in the dialysis industry, I think maybe so in healthcare in general, but particularly in the industry, that the turnover was really quite significant in staff. And so if you lose these champions, the change may fall away. So we worked on having them, the systems and processes really made permanent. Also creating, adapting, and using existing tools, which simplified the work and facilitated the changes. And finally, embedding steps into the routine processes. Woody, next slide, please. So during learning session 2, each site created a cause and effect diagram identifying causes of failure to conduct their goals of care conversations. Additionally, the importance of embedding the Pathways Project changes into normal, routine, facility policy and procedures was emphasized for sustainability to occur. And action plans targeted these factors. This graphic was utilized to plan tests of change. You can see here that it is looking at the normal pathway of a dialysis patient and looking at opportunities in the existing policies, procedures, and processes to identify the seriously ill patients and to conduct advanced care planning, shared decision-making, goals of care. So dialysis admission is an obvious place that this work could begin. Also, CMS requires a comprehensive assessment to be completed by the interdisciplinary team within about 30 days of admission, followed by an initial plan of care. So both of these, the assessment and the plan of care, are natural fits for incorporating these components of the project. Additionally, anytime a patient is hospitalized and returns to the facility, we encouraged, number one, asking the surprise question again, and reviewing where the team was in their ACP, shared decision-making, and goals of care conversations. Clearly, when a patient makes a change, such as moving to a long-term care facility, that also is an obvious point of care to revisit these conversations. Finally, CMS also requires that each month, the interdisciplinary team identify patients whom are unstable based on various criteria, and requires that they be reviewed monthly until such time as they are stable. And so again, we found that teams were very successful in incorporating these steps into their unstable plan of care. And finally, when a patient may make a transition of care to home, hospice, or palliative care.
And I'm going to jump in again. I think one of the things that was, I wouldn't say it was a tension, but was a learning for the teams, guided a lot by Glenda's role, which I want to emphasize, her role as the quality improvement advisor, where she's having monthly, sometimes more frequently than monthly, individual calls with the leader or the team at each site, and really coaching them through, what are you encountering? Let's brainstorm how can we do a very tiny Plan, Do, Study, Act, PDSA, small test of change that we'll talk about next month, right? So very individualized hand-holding. I called it the hand-holding job. But what was important, some of the sites did have kind of checklists around, did people have advanced directives or DNRs? And at the start of, and it actually kind of messes up our evaluation data a little bit, because at the start, they said, oh yeah, like we've got 100% of people with a DNR or a advanced directive in their chart, or that we've asked about it, because that's what the quality metric is. But as we worked through this with them, they began to have a much more expansive and comprehensive understanding. We're not just asking, do you have a DNR or do you have an advanced directive? Check, but we don't have it. The hospital doesn't have it. Nobody knows what's in it. You've never talked about it with your family. It's really much more about a conversation. And although it's good and it's ideal to get that documented in the record and have a formal advanced directive, that the conversation was what was really important. And then the brainstorming and the working with the patient and family about how to accomplish their goals. And we had some very creative and amazing things that people did, including, I'll just tell one story. 6 of our 11 sites were in New York City. And so we're hit by that very first wave of COVID, if you recall what that was like, hitting everyone by surprise. And we had nurse practitioners in particular calling families, doing telehealth calls with families to walk them through the decisions that they might be facing with their loved one in the hospital. And that was something that they would not, I think, have known, and they told us we would not have felt we could do that without the work we had done beforehand to feel like we knew that person, we knew their goals, and we knew their family enough to help walk them through it. So
yeah. And if I could add one comment too, I like this slide because you sort of at least get a little bit of the feel of the culture of dialysis centers. It's really sort of like a production line. They're bringing people in, they're giving them a dialysis treatment, they're taking off dialysis, they're sending them away, they're cleaning the dialysis chair and the machine, and they're putting the next person on. So really, I hate to say a widget factory, but really you're producing dialysis treatments. And so really people have commented, many people have commented, it's not really conducive to getting people to talk to each other and find out what's important and do all the things that we were trying to get them to do. So one of the things that we did, we didn't have, I think, unrealistic expectations. We said, not all your patients, focus on those that you believe are most seriously ill. Of course, some people objected and said, but we should really be having conversations with all our patients. And we completely agreed, but they didn't have time really to even do what we were asking them to do completely. So we helped them focus by identifying their seriously ill patients. And then we helped them focus even more so that when your seriously ill patient was hospitalized and came back, have a conversation, a goals of care conversation with that patient within 30 days. So as I think about it, we had several layers of helping them to focus on those patients who are clearly most seriously ill to try and get them to do the advanced care planning discussions to find out, what treatments the patient did not want, who they wanted to be involved in their decision-making, trying to improve their care throughout the continuum of care. All right, I just wanted to throw that in. Glenda.
It really feeds into this slide, Woody, about when we were assessing with the staff, their perception of the culture change that occurred during the project. We had some wonderful quotes that came forward. One, a social worker, when we said, well, what are you going to be doing to sustain this work? And she said, well, we've integrated the practices into our routine so well that they're now a natural part of how we speak to patients and address their concerns. And also the recognition teams learned that, in the beginning of the project, and we did education and coaching about conducting the goals of care conversation. And there were some very emotional situations that arose. And in fact, we had some cases that we coached and mentored teams about. but they learned that patients want to have these conversations and that they appreciate talking about these things. And that really was a major factor in some of these teams really moving forward and realizing, oh, I don't have to dread doing this, because the patients need and want this. And finally, we had a nephrologist leader that in a very busy Manhattan dialysis center that was severely impacted by COVID-19. And he reported that they now feel more comfortable having the goals of care conversations with patients and is again more normative. So from a sustainability aspect, we feel like that this normalization of these practices into their routine is a really good pathway to sustainability.
Right. And let me add that we really did teach communication skills. The very first learning session was a 1.5-day workshop on communication skills using the Vital Talk approach. And then when we realized when they came back for the second learning session, they really weren't having the conversations and still didn't feel comfortable, we reduced it to what's called the Ask, Tell, Ask approach and gave them a 3x5 laminated card with the questions to ask. And then actually I visited the dialysis centers and had Ask, Tell, Ask conversations with their patients so that they could actually see, oh, this is doable. So we really, to get them to implement the practice, we really did it in a lot of different ways.
Woody, I would just add that you modeling the conversations was such an effective component of this project.
With their own patients, because we modeled them with role playing on, it was in their dialysis center with their patients.
Right. And, Woody is just so empathic and compassionate in his conversations with patients. And he was able to model for them that, it's just walk up and start talking to the patient.
Yeah.
Ask them important questions and listen to what they have to say.
It's sad that palliative care is not better integrated into the care of dialysis patients in the dialysis centers, but this is not rocket science. This is implementing primary palliative care skills with dialysis patients in their dialysis centers. So that actually, the take-home lessons, that's the very first point. The present state of kidney supportive care or kidney palliative care is not pretty. I mean, we found a very low completion rate of advanced directives, of medical orders such as POLST or MOLST. They didn't know which patients, they did not assess patients to see which ones had decision-making capacity and which ones didn't. I mean, it just wasn't good, except for those few centers, and Laura could tell you more about that, those few centers that really were doing things much better than the others. It really did get buy-in for us, fortunately, with the nephrologist when we gave them a tool that actually worked and was very simple and could be done in 30 seconds on dialysis rounds, with each patient once a month. So that helped. And then they really, as Glenda reported, they were gratified by getting to know their patients better. I mean, that's the rewarding practice of medicine, is the clinician-patient relationship. And so they felt like they were enriched, and maybe it helped decrease burnout by really just feeling more of the sense of humanity about what they were doing. And then finding that they could actually set aside a little bit of time and do it as part of their dialysis workflow was a real aha moment for them. And so in the real world, we were able to show that at least some dialysis centers can implement advanced care planning and kidney supportive care best practices. They really improved on at least 2 of them, even if we didn't make headway on that third one that Dale mentioned to you. But really, we need new policies to improve access to specialist palliative care. One of the things in the third priority that was not implemented was palliative dialysis. And the CMS incentives are against individualizing and tailoring a dialysis prescription for a patient to the patient's values and preferences. They really were just all about the quality measures they had to submit to CMS. And was the dialysis index going to be high enough? And was the calcium going to be what it needed to be? And the hemoglobin and all these, lab test measures that really don't improve patient quality of life or their patient satisfaction with care or their patient experience of illness. So that was we need new policies, and our Coalition for Supportive Care of Kidney Patients is continuing to work on trying to get policy change. So I think that's, Laura, that's what we wanted to talk about, but we're happy to have you open it up for questions and comments.
Well, great. Thank you so much. That was really wonderful. And I have loads of questions myself. So if anyone would like to ask a question, please go ahead and you can either type it in the chat and I can read it out, or raise your hand. I'll try to call on you, or feel free to unmute yourself and ask one. And while you think about your questions, I have one, which maybe is a little bit of a hard one. But I'm just thinking, sort of taking this all in and reflecting on the whole process. And Woody, you'd mentioned sort of adapting learning session 2 to kind of reflect what they've learned. And I was just thinking, if you were going to do it all again with the big picture goal of these 14 practices, and the idea is creating a culture of supportive care in these centers, what would you do differently? Would you do a collaborative? Would you do something else? What would you focus on? Who would you involve? I'm just, if you had a chance to do it all again now, COVID aside, what have you learned that you would do differently?
All right. Well, I am a nephrologist, remember, so I'll give the medical answer, but then Dale and Glenda probably would answer it differently. So as a nephrologist, just recognizing that the CMS policies are against really transitions of care and palliative dialysis, I would probably not have that be our third priority. I would have introduced pain and symptom management as my third best practice to get them to work on, because nephrologists are really pretty good at writing prescriptions. And if you just give them a good paradigm, they can use it to treat patients. And we know that pain is undertreated dialysis patients, and symptoms are undertreated and under-recognized. And we have really good validated symptom assessment tools. So they did well with the surprise question as a assessment tool, and I think I would have given them that as well. So that's at least one thing I would say.
And I would respond from the evaluation, the overall setup of the project. We initially wanted to randomize sites into, or at least have control sites, even if they weren't randomized. And we couldn't get the cooperation of enough sites to agree to that initially. And we did some things that we thought would allow us to control for secular trends, but none of us ever anticipated a secular trend like COVID. And it really, one of the findings that we had was that hospitalizations went way down. Well, we don't know whether that's our intervention or that was just happening because of COVID. So if I were to do this over, and if somebody would give me like an extra $500,000 or $1 million, I would make sure that we had a stronger design, even though we thought this would be very strong, but we just couldn't have anticipated COVID.
Yeah. And Dale, if I can say something about stronger design and actually getting dialysis centers to participate, we even thought we would go to these dialysis centers that were already part of a shared risk model that would have stood to benefit from identifying their seriously ill patients and treating them in such a way that they would reduce the hospitalization, reduce the costs of care, so that they would have shared savings. But we couldn't even get them to jump on board. So really, you have to understand, even if you have a really good intervention, if the climate is not right, if the financial climate is not right, it becomes a real challenge. So we weren't able to recruit as many centers, dialysis centers, to participate as we would have liked. Oh, there's a hand up there, Laura.
Looks like Manju, would you like to ask your question?
Yeah, nice to see all of you, and thank you for sharing your experience. I just want to say this was such an enormous undertaking, and I just want to congratulate all of you, first of all, for really moving the needle in so many areas in supportive care here. So really, congratulations. My question for you is about supporting communication skills training and goals of care. What I think you described and what we heard in partnering with you is that there were many different models for how this was implemented at the sites. So some places had a nephrologist champion. Some places really relied on their nurses, nurse practitioners, social workers to be the agents of change. And there were clearly places where there were other nephrologists who were, you know, content to not be a part of the change, if you will. So what model or models do you feel were most sustainable? And if there is a 2.0, how would you go about, you know, trying to reach those folks? Or would you not try to reach them and really focus on the advanced practice providers and, you know, the other staff who were maybe more receptive?
So I can tell you, I would get the nephrologists who are the early adopters to delegate to the nurse practitioners and social workers the responsibility for implementing this initiative. I think the dialysis centers that did the best, at least in my mind, were those that had a nurse practitioner, social worker team really scheduling and having these discussions. I don't know, Glenda, if you agree, or Dale, you agree.
I agree with you that the delegation and I think that one component would be getting permission, if that's what it took, from the non-engaged nephrologists to let the team do their work. And in some sites that did happen, and others there was some resistance, so that would be one thing. Another thing that I would do in a 2.0 is to ensure that we had site-specific data ready early that we could provide to the teams, and that we could do more coaching based on their site-specific data and in utilizing data for information for improvement, which they lack the skills in now.
I like what my teammates have said. I'm trying to think if I have anything else to add. I think there were some times when there were physicians who, obviously nephrologists, who have tremendous authority and power in those settings, were getting in the way. There were a couple instances, but mostly that wasn't the case. So I think it is about the nephrologists empowering the rest of the team. And then we had just a lot from I think the social workers in particular, saying how satisfying this was for them. Because in the dialysis center, the social workers are often doing a lot. I don't know, those of you on the calls know about dialysis centers, but they often spend a lot of time doing transportation and insurance, things which are not kind of top of license for them. And so when they really got involved in, I have somebody who wants to go home, and I'm going to make that happen despite the difficulty of getting hospice services into them, they felt like they were working top of license and felt very satisfied. So,
Yeah, I don't know how much this audience knows about the dialysis reimbursement and the fact that their monthly capitation payments, the nephrologists are paid in part on how many patients they have on dialysis. So they are incentivized to put patients on dialysis. As it happens, I was scheduled to role model a conversation with a patient, an elderly dialysis patient who was significantly demented. And he was really so ill that he was unable to come, but his wife came. And so I had a conversation with the wife and with the nurse and with the social worker. The nephrologist was invited, but chose not to show up until after it was all done. But really, the wife explained how difficult it was and how demented her husband was and how she really needed help. And we really reached the conclusion that it would be most appropriate for him, the patient, to stop dialysis and for her to enroll him in hospice. And she was just delighted by the idea that she would be able to get some help and that she wouldn't have to fight with him every time he had to, he had his dialysis date to try and get him to get into the cab or whatever to get to the dialysis center. And then the nephrologist comes along. He was invited, but he didn't show up till afterwards. And he just said, absolutely not. He's going to stay on dialysis with no real compassion for what the wife was going through or for how well the patient was benefiting or not benefiting from the treatment. So you can sort of use that as perhaps the worst case scenario, but what clearly can happen when the incentives are wrong.
Yeah. The other thing I think, 2.0, and we are trying this in a project we're doing with the Rogerson Institute in the New York City area now, is get more specialist palliative care teams and hospice teams right involved in their cases. The dialysis teams are really isolated. Not only is the setting siloed, but for instance, the social worker is often the only mental health person that all those patients, those 100 patients are seeing, not just in the dialysis center, but in their life, right? And she typically, but there's some he's, the social worker doesn't typically have more mental health resources to call on for these folks and doesn't have spiritual care resources to call on. And so if bringing in that broader team from palliative care would be something I'd really like to figure out how to do. And of course, there are challenges on the palliative care side, which is there's not enough palliative care staff and capacity. And so.
Right, and the hospice barriers, which is partially policy with CMS and I guess, perceptions that is a real barrier to more hospice collaboration.
Yeah.
Right. But I don't think we want to be negative. We would like to leave the people on this call with the idea that we were able, as Manju said, we were able to move the needle. And really, we were able to get them to be more aware of the fact they do have some significantly or seriously ill patients that they can identify. We taught them that they can actually talk to them and find out what's most important, and they can put together an action plan to try and make sure that the patient's wishes at the end of life are respected. So at least we started to give them some tools. And as Dale said, now with this continuing work with the 11 Rogerson dialysis centers in New York City, we're really trying to teach them primary palliative care skills. And what's interesting, and Dale, I don't know to the extent to which you're aware of this, but there are all sorts of things going on that they're now calling me about, patients who refuse to continue to come to dialysis, but yet they're somehow still alive 3 weeks later. Manju will understand this. It's a bit long. And I said, well, call that patient, get them in, get lab work, don't have them die at home of a cardiac arrest. If they really have some residual kidney function, work with them. And the dialysis centers are so siloed that if the patient's not there, they're not reaching out to them, they're not calling them, they're not following up with them, they're not scheduling them for weekly blood tests just to sort of keep an eye on, have they regained kidney function and are they not really going to need dialysis? So really, we need coordination of care, we need continuity of care. I'm sure this group, I'm preaching to the choir with this group, right? They know all about how to improve care. But
and the other sustainability piece that doesn't show up in the formal evaluation, but a group that we were working with in the West, I won't say exactly where, they have created a whole, they've become part of some of the value-based models and have created a whole group within their practice that is rolling out just additional choices, including medical management, but has become the framework for them really enabling more people to do home dialysis. So they really embraced and took the notion of finding out what people want, and then the communication skills. They developed a video for patients. So there's been some wonderful work that has continued past the close of the project.
And spread.
What's interesting is that practice that Dale's talking about, a large practice, has hired a number of nurse practitioners to have the conversations and to follow these patients much more closely. which is really what's needed if they're deciding not to go on dialysis. So we're starting to see some of these practices. This is really doable in the United States. It's not just Canada and Australia that can do this well, but we have to learn how to do it.
Well, great. It's 8 minutes to the hour, or 7 minutes now. So if anybody needs to hop off, we try to end a little bit early. They can. I just want to thank you three, Dr. Moss, Dr. Lupu, and Glenda, for joining us today. It's been really wonderful talk. And I'm sure if anybody has any follow-up questions, they'd be happy to stay on for a few more minutes and answer them. But thanks to everyone, and thanks for the presentation today.
If you would take down our slides for a minute, just so everybody wants to see us and we can see them.
Hello, everybody.
Yeah. And
thank you all. Well, if nobody has any other questions, I have one last one.
Yeah.
Dale, you mentioned, and I know I think we've talked about this a little bit before, but kind of the shift in thinking that people experienced, right? Oh, they said at the beginning, oh, we're doing some of this already, and then they went through this whole process and like, oh, well, actually, maybe we weren't doing it that well. And that really, I think, speaks to the culture shift you wanted to have, right? People have a new way of perspective and thinking about it. And just from an evaluation point of view, is there a way you would assess that differently next time?
Oh my gosh,
or how you would approach that?
Yeah, that was very difficult. One of the things we did was, for expediency reasons, we used research assistants embedded that weren't our research assistants. We used the research assistants at each site. And we thought we trained them to do chart audits, which are what our big finding around how much goals of care conversations and how much documentation there was. So we thought we had trained them well, but we hadn't, because even the research assistants were embedded in their own culture of if there was a checklist and somebody said, check, I've checked that someone has an advanced directive, but it's nowhere in the chart. There's nothing about it, right? They were still checking yes at the beginning. So just from a research and evaluation standpoint, I think we would have done some reliability testing. We would have perhaps had, gotten some records and trained people to make sure that the reliability and that they were checking for what we wanted. We didn't, it seemed so obvious to us in retrospect. And it did show up at the end. We had to go back and really ask people. And the research assistant said, oh, what we're looking for now. Yeah, we've learned more about what we're looking for than when we started. So yes, that was definitely a research method place we could improve. And yeah. There's always possibilities to get better, more accurate data. I think we're always learning. Yeah.
Probably be better to use our own research assistants if we were to do this over again.
But somebody has to give us the money for that,
Yes.
It's very costly. So,
well
thank you guys. We appreciate the chance to share what we worked on, and appreciate you guys, our Stanford colleagues, for helping us measure the impact.
Yeah. It was wonderful.
It was exciting to work with you. Yeah. Are you planning to go to the ASN this year?
I think not.
I think not. We're going to take this one off, probably.
I'm still COVID cautious to a certain extent.
Yeah.
Understandable.
Are you, Manju?
I am. I'm going to take a chance.
Okay.
Are you presenting?
You can keep talking us up. Yeah.
Yeah. Well, it was great to see all of you.
Likewise.
Thanks, everybody. Bye-bye.
Bye.
Thank you so much.
Thanks.
Bye.
Bye.